Our patient is a 47-year-old male that presented with right flank pain. CT scan done showed right PUJ obstruction, for which he opted for laparoscopic dismembered pyeloplasty. So the procedure is ongoing here. That's the varus needle insertion. Initial pressure set at 70 millimeters of mercury for trocar insertion. So that's the initial laparoscopy, following insertion of the first 10 millimeter trocar. So the procedure has started here. We are reflecting the peritoneum over the kidney here with the use of ultrasonic device. So the peritoneum was being reflected while leaving the geritas fascia on the kidney. At this point now, the geritas fascia has also been reflected, exposing the renal pelvis. So at this point, the renal pelvis has been incised. You could see the gush of urine following that. An oblique incision is now being made. From that point of incision towards the UPJ, making sure that the lowermost part of the Pelviureteric junction is still left on the kidney side to avoid tension on the repair. So the incision is almost complete here. You can see the lowermost part of the pelvis is still left on the kidney side. We are also leaving a redundant part on the ureteric side to make handling easier, especially during the repair. So at this point we are spatulating the ureter. Spatulation should be at home. Just one sweep of spatulation is usually okay. So now we are commencing the repair. Note that the first bite is usually just short of the apex of the new PUJ that is being formed. We aim not to put that first suture directly on the apex, just short of it. So this is a repair of that's the posterior wall anastomosis ongoing here. We are doing a continuous anastomosis. Sorry, I mean a continuous repair using a PDS suture. Know that care is being taken here not to handle the ureter. The part that is being held is the part of the tissue that is going to be resected at the end of the whole process. So at this point we are concluding the anastomosis at the posterior wall. So that's the final note of the posterior wall repair. So you can see the repair done in a continuous fashion. Now we are commencing the anterior wall repair. Still the same principle. The first suture here is usually, first bite here is usually short of the apex of the new PUG. See the first bite there, not directly at that apex, to reduce the chances of suture formation, as well as to make for an overall a better outcome of this dismembered pyeloplasty. So this first bite is an interrupted suture. So we are going to cut it at this point and then proceed with the insertion of our DJ stent. So at this point we are inserting the DJ stent. So the DJ stent is well in place here. So we'll continue with the anterior wall anastomosis repair. So the repair here, after the insertion of the DJ stent, has been continued in a continuous fashion, taking care not to handle the ureter in the process of the repair. So the anterior wall repair is complete here. So the knot is being tied. So what you have left on the ureteric side is the redundant part of the pelvis that is going to be cut off. So we're now cutting off that redundant pelvis that we've been using as an anchor all through the repair process. So following this, the remaining part of the pelvis can then be closed up. So the repair is complete here. Repair is complete here. So we're going to place a drain, remove the lever anchor that was put in place at the beginning of the procedure, taking care to be sure that there's no bleeding on the wall. Yes, there's no bleeding here. We'll place a stent. And the patient did very well, was discharged after 3 days. Drain was removed on the second day. Thank you for watching.